of an inflammatory condition and leaves out all of the asymptomatic spread and completely ignores nursing homes where over 40% of the deaths are occurring. And then in several states, not just New York, there are rules now that some of them have been rescinded, some of them have just been written, saying that you actually have to return patients to nursing homes who are COVID-19 positive. It's like a kindling to a fire because it's a very, very, very susceptible population, which is the point you're making. So the messaging on this, on the one hand, we're hearing in the media that there's a lot of asymptomatic spread, a lot. On the other hand, we're hearing something about a death rate which doesn't fit together with the idea of the asymptomatic spread, and Dr. Atlas just put that together for us. Go ahead, Dr. Atlas.
Yeah, sure. So I'll make a couple comments just to highlight what you just said. It isn't just New York with the idea of nursing home patients not being protected, of course. It's all over the country. I live in California here. It's more than 50% of the deaths in Los Angeles are in nursing homes. Some states across the country, 50, 80% of deaths are in nursing homes. And even the countries in Europe that are, in my opinion, dealing a little bit more rationally with reopening have the same problem. They've ignored the vulnerable people. For instance, Switzerland has 53% of deaths in nursing homes. Sweden, 70% of the deaths in Stockholm are in nursing homes. And so it wasn't just the U.S., it wasn't just certain states, but it will go down as the historic tragedy of public policy in this. Now, and if I can comment on the school situation, you brought up this rare exception, and people are familiar with this Kawasaki disease sort of variant, which is this, very serious condition that's multiple organ system involvement. But, you have to realize, you have to have a medical perspective here. Kawasaki disease is very rare, and it occurs in 2,000 to 5,000 children per year. In fact, it's treatable on top of it. Unusual disease, a very small association. Intake. Rare disease. I mean, this is very exceptional, and it's really taken over a narrative because somehow the things have been really sensationalized in the news. So parents should be reassured that not only are the schools super safe environments, as they are right now, with no protective barriers, but, we also are fine with the teachers. I mean, K-12 school teachers, it's a young profession. Half the school teachers in the United States are 41 or under, and 82% are under 55. And remember, I said that if you're under 60, your likelihood of having a problem here, the risk is actually less than or equal to seasonal flu. We don't shut down the schools because some teacher might be in a high-risk category for dying from the flu, by the way, and it's the same kind of person. And there are exceptions to the teachers, and we know how to protect vulnerable people. We have learned a lot about social distancing and hygiene, and if there's a teacher who is fearful or who, needs protection because they are in a high-risk category, they can socially distance themselves. And in fact, in my opinion, if they're really that fearful, they can teach from home. But the children themselves are at essentially zero risk from this. And secondarily, there's data from all over the world now emerging that children only rarely even transmit infection to adults, even their own parents. And so there's been a lack of sort of understanding what the actual data is here, and it's very harmful because I don't think you have to be a doctor to understand what's happening when we close schools. It's super harmful to our children. It's most harmful, by the way, to the lower socioeconomic group families who don't have this sort of paraphernalia, I would call it, of the affluent, of iPads and all kinds of materials. Long-distance learning is not a substitute for school. We already see that there's a 30% drop in reading level from long-distance learning already. In the Boston area, 40% or more of students are not even logging in. And then when we combine that with the lack of socialization, healthy physical activity, group interaction, we send our children to school for a lot more than just learning what's in a book.
Dr. Atlas, I'm sure we're going to want to have you on our About Our Kids show where we talk about this exact issue. But I also want to tell you, I keep looking at my daughter's computer, and this is going to get me in trouble, to see if there's any ivy on it, but I can't find any. I'm very disappointed in the tuition I'm paying, and no ivy on her computer, if you know what I mean. Now, I want to throw you a question from our program director, Beth Amin. Very smart question, which is how this is varying from one place to another. In other words, you have this lockdown. It's causing secondary disease, deaths, all this damage you're talking about to education and learning. If you go around the world, how is this varying from place to place? Is there a structure that would have prevented this from occurring? A way to handle COVID-19 that would have kept this from occurring?
Yeah, I mean, this is a great question. And when we look at what other countries have done, and I'm particularly pointing to some of the countries in Europe, we can see that no one handled this perfectly because, of course, this is serious disease. It caught everyone blindsided, essentially. But when we look at what was done, history will probably look back and say that a targeted policy without total lockdown, like something like what Sweden did, was a lot more appropriate. And except they really bungled their nursing homes again. And so, you have to remember, people wrote, I'm talking way back in even February, early March, that this targeted approach of protecting the vulnerable should have been implemented, and no one did that well. But when we look at these other countries, there's a lot more sort of sanity about opening up without mandating things and without really putting in mandates that aren't necessary, because you have to, again, we have to be cognizant. Okay, we want to protect people, but when you start saying people need to wear masks outside, I mean, I'm living in California here. I go outside to run. I see people jogging on a track alone with no one around them wearing a mask. I see people riding in their cars alone wearing a mask. I'm not making fun of the people. I'm saying this is a manifestation of the fear injected by statements of leaders, many of whom are in New York, but also my state is the same in California. And it's just not evidence-based. We need to look at the science, but then there's a second element, and they don't really teach this in medical school, for instance, and that is logic. You have to do deductive reasoning to understand how to use that information to come out at the other end with an appropriate policy. And this is very critical and difficult, I think, and not necessarily a learned skill.
I want to challenge a question I have in my mind that has to do with an article I wrote in the Wall Street Journal about masks, and you just hit on the absurdity of them in certain settings. They're not absurd overall, but to the point you're making now, do we know that there's asymptomatic spread of this virus, right? And that freaked out a lot of people. But A, we don't know how much asymptomatic spread there is versus mild symptoms, and B, and this is most important, we don't actually know how asymptomatic people are spreading it to each other, do we?
Well, okay, this brings up two issues I want to touch on. Asymptomatic spread is estimated to be almost 50% of people who are infected when you look through all the literature. That's a positive. That's not a negative. It's been falsely portrayed as a problem. The reality is, when you have spread among low-risk people, you're inducing people to get immune. That's a good thing for populations. The second thing I want to bring up with the mask, if you have a situation where you think you're going to be coughed on in your face, then you might want to wear a mask. That's different from saying mandated mask and things. I'll give you the latest on this.
Agree completely.
Website
agree.
says no healthy people need a mask except if you're taking care of a sick, symptomatic patient. I'd like your listeners to understand that. The WHO says no mask needed for healthy people outside of taking care of a sick, symptomatic patient. That means not in a bar, not in a restaurant, not in an office.
And by it comes out of, one of these things that I wrote my fear book about, which is some kernel of a comes out. They put some hamsters in a cage and they blew with a fan. One cage is covered with a mask-like covering. The other cage has no covering. Guess what? The hamsters, and there's only a few of them, mind you, the hamsters in the cage get COVID-19 more often. Then somebody tries to apply that to American society. But excuse me, first of all, we're talking about a couple Secondly, we're at you at high speed with a fan. So that's part of the problem with messaging, the way it just gets dilated and suddenly it's thrown around and everybody thinks it's dogma, and that's led us to a very tough place. You're listening
I couldn't
to
agree more. I saw that study. I hate to interrupt, but that is exactly the correct analysis that you just did. That study is something that is not necessarily transferable in any way to what we're living with here as human beings. Although I would say I recommend if anybody's going to blow COVID-19 at a hamster that they have as a pet, they could put a mask on.
You're listening to Dr. Radio Reports, Coronavirus, COVID-19, what you need to know right now about the pandemic. I'm Dr. Mark Siegel. I'm the medical director of Dr. Radio. I'm a professor of medicine at NYU Langone Health. I've written books on pandemics and fear of pandemics. It's an honor to be joined by Dr. Scott Atlas, who is a really world-renowned health policy expert. He's a senior fellow at the Hoover Institution of Stanford University. He's a member of the Hoover Institution's working group on healthcare policy. He's a neuroradiologist. He's a friend and colleague to our dean, Dr. Robert Grossman, and our chairman of radiology, Dr. Michael Recht. Give us a call if you have a question about how COVID-19 has affected other parts of our healthcare sector. Give us a call at 1-877-698-3627 or email us at docs@SiriusXM.com. Scott, can you do a little bit of a deeper dive into this, how it has affected the rest of our healthcare system, and give me some clue to regional variations to that, because we're stuck in the hot spot here, and unfortunately the media has broadcast that. Clearly different regions have different issues and experiences with COVID-19.
Yeah, absolutely. And, New York is the New York area is a very different place. I mean, you're talking about all of the issues, of course, that you and your listeners know, but you're talking about, more than 1 million people commute in, half of them on cramped trains. It is a very different environment, and the hospitals were, in some cases, overwhelmed. And that overwhelming of hospitals, which also happened in Italy to some extent, is a cause of a higher fatality rate in and of itself, because you get more in-hospital or what's called nosocomial infections and spread, and you really get a lot of issues that other parts of the country, in fact, almost no other part of the country saw, because there wasn't that sort of milieu, really. So when you talk about the healthcare itself that was shut down, it was very, very important care, as I've outlined in a lot of pieces, and I said here, but it's also things like urgent care was down 40%, urgent care visits. Physical therapy, 2/3 of physical therapy visits stopped. I mean, it had a tremendous impact. What's happening now, and I have some data from various parts of the country, including, for instance, the Northwest and South, is that they're starting to come back. There is a sort of a gradual realization and an effort by the doctors to call up patients. At Stanford, about half of patients were refusing, as of a couple of weeks ago, even when called by the neurosurgeons to come in for their really potentially lethal brain lesion. They were still refusing to come in. There's a tremendous amount of fear to overcome, but it is gradually coming back. It's going to be difficult now. We've set up, unfortunately, a problem with schools because kids are coming back into the swing of things. They've missed vaccinations. Some of them will not have been vaccinated. This is really a public health issue now that we can't screw up again. We have to really be careful here and make sure that there's a much bigger effort for the things like vaccinations. Other things, I mean, there are thousands and thousands of biopsies every week of potential cancer that have not been done. So there's going to be a big pickup in these things. I think we've learned quite a bit about mobilizing resources now, and also how to not sort of isolate other medical care. I'm hoping that a lot of lessons have been learned about this as we move forward and get people back into the healthcare system.
Scott, before you go, I want to clarify one thing about masks, because, again, I've written about this extensively. It's a tough topic, actually, to cover. The purpose of a mask is theoretically to protect those around you from your coughing and sneezing if you're sick, if you have a respiratory infection. The reason being that actually coughs and sneezes can travel up to 12 feet, not 6 feet. And the real question with COVID-19 is, does it hang in the air or not? That's not really been determined, but we're talking about respiratory droplets here. We don't know know how much a mask actually protects you, even if you're symptomatic, by the way. There's been 2 studies recently that have actually disagreed on that. And in terms of incoming, if you're standing there wearing a mask and someone has it near you, we don't know whether having a mask protects you at all from incoming, because it can actually get in through your eyes, through your skin, it could land on your hands and go to your mouth. Presumably, if somebody that's very symptomatic around you had it and you were wearing a mask, it would afford you some protection. The key to everything I said here is the word symptomatic, because we don't know if you have COVID-19 and you're wearing a mask and you're not coughing, whether that mask decreases your spread to those around you or not. It can't hurt. It certainly can't hurt, unless, and I want to make the fear message here, unless you think, I got that mask, I'm protected. I got that mask, nobody can harm me, I'm impervious. And then you go right next to somebody who has COVID-19 thinking you're protected. So it sends a false sense of security message.
Yeah, and I would add something else, which is that no one is saying you are not allowed to wear a mask. If you want to wear a mask, that's okay. You don't have to go into a restaurant if you feel uncomfortable. You don't have to enter the bar. That's very different from saying it's worth having a mask. In fact, it's counter to what the WHO said, except, as I said, for people who are taking care of somebody who is symptomatically sick. There is no need to have a mask if you think someone's asymptomatic and might have the disease. That's not what the WHO is now saying.
And I want to add... I just want to push back a little.
Look at the website of the flu for the CDC as perspective here. The same high-risk people to die from the flu, they have a separate website page on what their CDC recommendation is for people high-risk to die from the flu. Okay. There's nothing about masks. Nothing. Just isolate from symptomatic people.
I want to so our listeners have broad perspective. Societies like Asia, Hong Kong, areas where people wear masks regularly, if it's part of a philosophy of awareness of social distancing, it depends on why you're wearing it and what your purpose is. I am not against it. I'm against it being seen as a cure-all in a situation where it may have a limited use. And as Dr. Atlas says, different societies put it differently. Scott, final thoughts before we go to break. Just a couple seconds left.
Yeah, final thoughts are, I think everybody needs to really understand that we have learned a tremendous amount about this disease. It's not the same thing that happened months ago. We don't have to have fear. We can use our logic now. The curve that was necessary to flatten was flattened, and we know who to protect. And I think we need to focus now on allaying the fear and getting people back to normal function, not a function that's restricted unnecessarily, because the policy itself is severely harmful. So we really need to move forward with some common sense here.
Thank you very much. That's Dr. Scott Atlas, another great doctor. Pleasure and honor to be joined by him. He's the senior fellow at the Hoover Institute of Stanford University. Dr. Atlas, thank you very much for joining us today.
Thank you very much for having me.
When we come back, we'll be talking to Dr. Jill Gamberg, who's a Canadian doctor who's practicing in Australia. She's got a mental health forum going on internationally, virtually, and she's also on the front lines against COVID-19 down in Australia. We'll be right back.